younger friends. And I would like to thank Dr. Vittal for inviting me for this lecture. I'm truly honored, sir. Beginning with my lecture, antibiotic stewardship. Anybody, what is the literal meaning of stewardship? From PGs and all, so residents. What does stewardship mean? Stewardship actually means, literal meaning is taking care of something. Like when we are sick or critically ill patients, what do? We prescribe them antimicrobial agent, antibiotics to take care of them. But in the reverse manner, we also have to take care of antibiotics so that we are already facing that problem of widespread antimicrobial resistance. So often we see the report, this so-and-so bacteria isolated, it is resistant to all of them. And then we are stuck up what to give. So antimicrobial stewardship is nothing but a bundle of interventions that are aimed to counter the emergence of antimicrobial resistance. But why does this bacteria develop resistance? Yes, why do they have the bacteria? Come on, yes, give me some reasons. Anybody? It's not that difficult game. How do or why do bacteria or any microbial agent develops resistance against antimicrobial agents? Yes, very good. I like interactive sessions, yes. Mutations. Okay, that is something that is not in your hands. Something happens by the law of nature. We can't help it. Okay, that is one of the mechanisms. What else? What contributes to development of? One is, I take your point. Exactly. Both underusage and overusage of antibiotics leads to this problem. And it's not like that this thing is happening at PhD level or something. Even tertiary care institutes have irrational prescription of antibiotic, least to say. Here we see fever for 3 days, and the resident has prescribed Typhiloc, which is a combination of antibiotics, suspecting it to be enteric fever. Too early to suspect with a fever of 3 days. This one shows diagnosis of old roadside accident, acute viral hepatitis, and lepto-IgM positive. I presume the patient was given treatment for both viral hepatitis and leptospira. But is it common a person to have both at the same time? Again, some irrational prescription is there. Diagnosis labeled as tubercular meningitis. The first IV agent I see is ceftriaxone. These are very common practices. We try to cover with everything. Pata nahi report mein kya aayega, kya nahi aayega. Let's give the best shot, and the best choice is combination cocktail of everything. But this is not the best approach. And that, I would say, irrational or indiscriminate use of antibiotics is most common setting is in the settings of not ICUs, because the patients are already critically sick. We don't have that much of time to wait for investigation. We have to protect them, but it shouldn't be there at least in OPDs. Now let's see. We have a 45-year-old male has fever for 3 to 5 days, which is high grade, not responding to conservative treatment, antipyretics, has body aches, myalgia, pretty much similar to a viral prodrome. On the top of that, patient has certain skin rashes. What do you make out of it? Diagnosis? See, all the dermatological diagnoses are usually the spot diagnosis. It has chickenpox because it has dewdrops on rose petal appearance. It is with a clear fluid-filled vesicle on the base of on an erythematous base. I'll skip that one. Yes. The skin of the face is red, thickened, tender. Slapped cheek appearance. Diagnosis is erysipelas. On a younger child, the quality of picture is not that good, but the rash is of measles. Everybody must be knowing this thing. Usually find it on feet. Meningococcemia. Another patient with same history, but a different type of rash. Diagnosis is, it is a black thing that has gone dead. We call it eschar, seen in scrub typhus. Diffuse erythematous rash, which is blanchable, lower limb, dengue, very good. So what I'm trying to say, there are very many possibilities for a patient with fever with skin rash. Some of them happen to be viral, some of them happen to be rickettsial in origin, some are bacterial, pyogenic in origin. So making a right diagnosis will lead to the right prescription. You can't prescribe antibiotics for dengue. Scarlet fever. So there are so many things. Some of them are all it. What is this diagnosis? Yes? Herpes. No. Herpes has a dermatomal distribution. The lesions are quite discrete and not that red. On the chest, commonly seen acne vulgaris. What is it? I would appreciate if other members of the audience can also contribute or be interactive enough. Sty? What is the treatment for it? Yes, louder. And? Epilation. You take out that infected thing and you don't need to prescribe antibiotic, not even topical ones for it. So coming back to antimicrobial resistance, why does it happen? Someone said mutations, which can be either primary or secondary. Primary means the infective agent at the time of entry into the host was itself resistant, and secondary is during the course of infection it develops resistance. The reason could be over or underutilization of antibiotics or antimicrobial agents. Shortage of diagnostic tools. At times you're not sure whether it is of bacterial origin, viral, fungal, we tend to prescribe things. If the patient is critically sick, we have no way out, we have to cover for majority of them. But yes, if the patient is hemodynamically stable, is not that critically sick, we should preferably wait for the investigations. Maybe like a patient, suppose a patient who is on case of rheumatoid arthritis and on steroids for quite some time and develops pneumonia, which is not getting cured with routine antibiotics, what will you suspect? Is there a possibility of maybe fungal pneumonia in those patients? What test will we perform to diagnose it? Heard of procalcitonin, heard of beta-D-glucan? A negative procalcitonin and a high beta-D-glucan is highly suggestive of fungal infection. But the problem is we may be short of diagnostic. Beta-D-glucan is not readily available even in my institute, and if the patient gets it done from outside, it costs around 7,000 to 8,000 at least. So sometimes we are short of diagnostic tools. Hand hygiene, quite obviously, so that we do not cross-transmit infection from one infected patient to other non-infected patients. Farming industry has been blamed for indiscriminate use of antibiotics in their cattle feed and poultry feed, just to make sure that their poultry is alive and kicking and they don't suffer an economic loss because of loss of bulk of those cattle or poultry. So what they do, they mix heavy dose of antibiotics in their feed and feed them so that they don't fall sick and they're able to sell them. Like we discussed, the OPD syndromic approach to fever with skin rash. Likewise, patients with respiratory illness can also be on clinical basis easily we distinguish into URI and LRI, but upper respiratory tract infection and lower respiratory tract infection. Do the patients of upper respiratory tract infection deserve a course of antibiotics? Never? If so, in which conditions will you give? Again, it is a common practice. Patient 2-3 दिन के साथ भी आता है तो everybody does give him some cefixime and give or levoflox, give some azithromycin. That's not the case. Only in patients who have persistent or worsening symptoms beyond 5 days, they may be put on antibiotics. Patients with non-responding fever, patients who have immunocompromised status for whatever reason, whether it is primary immune deficiency, HIV infection, patient on steroid or chemotherapy agents, then only. Even for lower respiratory tract infection, if the patient is not requiring oxygen supplementation, hemodynamics are stable, and chest X-ray is normal, even those lower respiratory tract infection can be managed conservatively with antipyretics and nebulization. Only those who are oxygen requiring, have some hemodynamic alteration, or have some definite patch on X-ray are the candidates who will be prescribed antibiotics. Urinary tract infection, everybody sees those patients. What do you think? A patient comes to you with complaints which are highly suggestive of urinary tract infection. What will you advise in the prescription part? Will you give antibiotic at the outset or not? Depends, there's some catch. If the patient has upper urinary tract infection, that is beyond urinary bladder, higher up comes pyelonephritis, pyelonephritis. Those conditions are organ threatening, definitely they will need antibiotic. Or if the patient has underlying immunocompromised status, whether irrespective of whether it is upper or lower UTI, upper or lower urinary tract infection, he or she will need antibiotics. But patients who are otherwise healthy and have lower urinary tract infection, be it cystitis or urethritis, should wait for culture report. We are not preventing anything devastating by prescribing antibiotics 2 days earlier in a case of simple UTI. You can give symptomatic management, you can give antipyretics and you can give antispasmodics, but wait for culture report within next 2 days. Another clinical syndrome, frequently patient visit with acute febrile illness with jaundice. There are multiple diagnoses to it, ranging from acute viral hepatitis, cholangitis, liver abscess, leptospirosis, scrub typhus, all of them, complicated malaria, expanded dengue syndrome. All of them can cause derangement of liver function test with visible jaundice. Out of these, which one are the ones that will not require routine use of antimicrobial agents or antibiotics? Sir knows everything, but the residents should come up with the replies. Acute viral hepatitis is one of them. Okay, yes or no? AVH antibiotics, yes or no? No. Cholangitis? Yes. Liver abscess? Yes. If it is a solitary liver abscess? Yes, but which one? Metronidazole, because a solitary liver abscess is likely to be amoebic in origin. Don't give peptides, don't give ceftriaxone, don't give monosef, all those drugs. Leptospirosis, yes or no? Yes. Scrub typhus? Yes. Which one? Doxycycline. Ma'am, the exercises for the residents. Complicated malaria, although it will require antimicrobial agent, but it is not the usual antibiotic, it's anti-malarial agents. Drug of choice? Complicated malaria? artemisinin based therapy क्या देते हैं इंजेक्टेबल? Felsigo? Artesunate, yes. And expanded dengue syndrome, again it is symptomatic management, no antimicrobial agent. So with the same clinical presentation, you have to hit the diagnosis sometimes solely on basis of your clinical knowledge, at times with the help of investigations, like we saw in case of urine culture. However, there are certain situations when the presentation is severe enough or it is life-threatening, like meningitis, patient with sepsis or multi-organ dysfunction, severe pneumonia, infective disease. All these patients will require empiric antibiotic therapy. You are justified there to give antibiotics without any available culture report, just solely on the basis of clinical diagnosis, local epidemiology, and local antibiotic resistance pattern that you observe in your workplace. So for what it was, see, antimicrobial stewardship is not solely the job of the clinician. It is a multidisciplinary approach. You have to involve microbiologists also. There has to be one pharmacist also. So there is a group of people who take care of these things. What microbiology people tell, and the clinician should also have some basic knowledge about the performing the right test with the right sample at the right time with right transportation. What does it actually mean, right test? Can you give me an example? Because most of the times, the tests to diagnose a particular disease, they are standardized. कि आपको टीवी डायग्नोज करना है तो आप जो भी सैंपल लेंगे उसमें CB-नेट भिजवा रहे हैं, ग्राम्स AFB ट्रेनिंग कराएंगे, आपको इन्फेक्टिव एंडोकार्डाइटिस देखना है तो ब्लड कल्चर कराएंगे एंड इकोकार्डियोग्राफी कराएंगे. तो व्हाट डू यू मीन एक्चुअली बाय देन राइट टेस्ट इफ एवरीथिंग इज सो वेल स्पेसिफाइड? We all had gone through Anant Narayan in our UG days, microbiology, enteric fever. The sequence of test was Basu. First week is, second week is, third is, and fourth week is. So that is the right test. Which week, which test to go for? Right test. Like a patient with the fever of 3 days shows thrombocytopenia for dengue. We all know there are 2 tests available. Which one? And dengue serology. Which one will you perform? Before 1 week, NS1. After that, serology for IgM. So there are certain scenarios where we have multiple choice of investigation or test that you can perform, but you have to judge which one is the right for that type of patient with that presentation. The right sample. We also must know what sample is to be sent for. Like, take a case of pneumonia. How do we diagnose pneumonia? On etiological basis. Clinical diagnosis is okay, patient has fever, some chest, shortness of breath, cough, you perform an X-ray, there is a beautiful patch sitting in there. Clinical diagnosis of pneumonia is made, but how do we make etiological diagnosis of pneumonia? किस वजह से है, कौन सा एजेंट है, क्या सैंपल भेजोगे? स्प्यूटम, कलर ऑफ स्प्यूटम से आपको बैक्टीरिया आइसोलेट हो जाएगा? कल्चर सेंसिटिविटी भेजोगे, लेकिन सैंपल क्या होगा? Who said blood? Who said blood? Excellent choice. The definitive diagnosis, if you read Harrison, the diagnosis of pneumonia is based on blood culture, not on sputum culture. Why so? If it is a respiratory tract infection, why not to get sputum culture and straight away have a diagnosis? Why do we need blood culture? Anybody? Because the upper or lower respiratory tract is not a sterile tract. We breathe in air, we inhale microbes with that. So the sputum has higher chances of getting contamination with normal commensals, whatever we are inhaling with the air. So that's why we do not go for sputum culture rather than blood culture is the gold standard for diagnosing pneumonia. Likewise, catheter associated urinary tract infection. What sample will you send? Of course, the sample would be urine, but from where? Patient urine tract is connected with a Foley's catheter, which is connected to a urobag. Where will you take the sample out from? Yes? Suprapubic. Patient is already having in ICU, has multiple lines. One more invasive intervention would you like to do to diagnose UTI? You will call your surgery friend for suprapubic and he will come? No. Otherwise, even otherwise it is not indicated. Something, you need to take urine out, but from where? Will you open the urine bag and put it into the catheter or tubing? Because the urobag also has tubing, there is some urine in it. Will you puncture the tubing part or the catheter part? Why so? because the site of collection has to be as proximal to the urethra as possible. And secondly, the Foley's catheter is made up of rubber, so it closes the gap, seals it off after the puncture. So this is the importance of recognize which sample from where. And nowadays, even when we send blood cultures, we don't send it single. We send it always send it pair. In pair, because pair, when I say pair, it means two things. From two different venipuncture sites, and both samples will go for both aerobic and anaerobic cultures. Same goes for what we frequently in ICU, we do ET aspirate and send it culture. But again, as I told you, the respiratory tract is not a sterile tract. It has high chances of getting contamination, isolating commensals and all that. So we always prefer to take multiple samples. Yield of the same infective organism from multiple samples is much more significant than getting one report from one sample. Foley's catheter, we already discussed that. Whether you take earlier there was a trend of getting you, whenever suspecting catheter-associated unitract infection, we'll take out the Foley's, cut the tip, send in a specimen for culture. Do we practice it now? No? You people do it? Not recommended nowadays, because any foreign material you place in human body has a tendency to develop something called as biofilm on its surface. That biofilm on the surface of Foley's will also transmigrate to the tip of the Foley's region. And if you isolate that is not the actual causative agent, but you are isolating the organisms which are already sitting harmlessly on the biofilm of any foreign material. So we don't do those tip cultures, be it Foley's catheter or endotracheal tube. Transport. Just a word of caution. We receive patients in emergency at night time, some meningitis patient, infective endocarditis patient, pneumonia patient, and we take the sample because those culture facilities at times are not available round the clock. What we do, we take the sample and put it in the fridge, which is not to be done again. All the supposedly sterile specimens like CSF, blood, in an otherwise healthy person will not be infected, will not have commensals in it, will not have resident flora, nothing. So all those samples should not be refrigerated, because refrigeration overnight promotes growth of fastidious organisms. So what will you grow next day is not what was actually the infective agent, but something that could sustain that low temperature for 12 hours, and that will grow. So naturally sterile samples are not to be refrigerated. They are to be kept at room temperature only. And a word about how do the microbiologists perform antimicrobial testing. Earlier days we all have seen in our microbiology labs the disk diffusion method. Whichever area does not have that pale yellow color means the bacteria is not growing in the vicinity of that drug, and the bacteria is supposedly sensitive to that drug, because it is not able to grow in its close vicinity. Nowadays, we have moved on to automated equipments. They keep on churning the sample and keep them warm, so that we can have a growth much earlier. The conventional disk diffusion method and culture sensitivity will take 48 to 72 hours. These automated equipments can give you culture report within 12 hours. This is what we are using at GMCH. And whenever you have a growth, you have to decide whether it is a contaminant or actual pathogen. And that contaminant could be a normal commensal residing in that place peacefully, or colonizer, which is usually not there, and it is isolated from that sample, but is not the cause for disease. Anybody can give me an example of isolating a commensal from clinical samples? ब्लड कल्चर रिपोर्ट देखिए आपने कभी, जिसमें लिखा होता है coagulase negative staphylococcus isolated.
Dr. Pritam, your time is, please.
All right, sir. Just 2 minutes maybe more. Skin contaminant, when you're taking blood culture, if you don't disinfect it properly, you will grow commensals. Colonizers like aspergilloma in tubercular cavity. It is not causing the cavity. The cavity was because of tuberculosis, but aspergillosis quietly sitting there. Finally, what report you get? It says sensitive, intermediate, resistant, but it is a qualitative kind of reporting. It doesn't tell me the quantitative aspect of the report. That means how much good one sensitive drug as compared to the other sensitive drug. Number 1 and 2. Something is sensitive both peptides and say meropenem. Which one should I choose? From that simple reporting, we have moved to something called as BMQ, breakpoint cluster minimum inhibitory concentration quotient. In nutshell, higher the BMQ, better is the drug. Take this example, urine culture shows growth of Klebsiella, imipenem minimum inhibitory concentration. I hope everybody understand minimum inhibitory concentration is 24, for cefoperazone MIC is 16. Which one drug will you give? The one with lesser or more MIC? Lesser. That means you require lesser quantity of drug to be effective. But then you get clinical breakpoint of 50 for imipenem and cefoperazone 24. Which one will you choose now? BMQ, breakpoint divided by MIC. For imipenem it is more than 50 divided by 24, more than 2. For cefoperazone 24 divided by 16, less than 2 at least. Which one will you choose? Imipenem. Just remember those higher antibiotics, clindamycin, linezolid, macrolides, and tigecycline are actually bacteriostatic in nature. Don't be confused that these are higher antibiotics that will cure the patient better. They are bacteriostatic in nature and not bactericidal. To conclude my talk, yes, any takeaway home message? Anybody? What you gained from this talk?